Started. So good afternoon, and thank you for joining the Kentucky Opioid Stewardship Outpatient Program for our webinar today. My name is Shanna Jaggers. I'm the outpatient pharmacist for KYSOS, and I'm joined by my colleague, Marilyn Connors, who is our outpatient physician consultant. Marilyn, can you hear me okay?
Yes, I can.
Perfect, thank you. So before we get started, I'd like to take just a few moments to review some housekeeping items. For attendance purposes, please type in the chat box your name, profession or title, and hospital or clinic that you are affiliated with. We do ask that everyone please mute your line throughout the presentation and hold your questions until the end, when you can then unmute your line or type your questions in the chat box. This webinar is being recorded and it will be posted to the KYSOS website under the section entitled Presentations and Recordings. The website can be found at www.kentuckysos.com. Be sure to spell out the full name of Kentucky. And we've also posted our website in the chat box. The title of our presentation today is From Prevention to Cure: Synergistic Benefits of Hepatitis C Care for Patients with Opioid Use Disorder. And it is my pleasure to introduce our speaker today. Katie Gardner is a public health nurse and health educator with 17 years of experience in clinical care, including harm reduction and infectious disease care and prevention. Katie received her RN at Bluegrass Community and Technical College and her bachelor's degree in nursing from Eastern Kentucky University. She currently serves on the board of the Kentucky Youth Health Network, which works to create public awareness of health risks and promote healthy outcomes for Kentucky youth. In her current role as the program coordinator for the viral hepatitis program at the Kentucky Department for Public Health, Katie focuses on increasing hepatitis C education and care in communities most impacted by hepatitis C and the overdose epidemic. So Katie, thank you so much for speaking to us today, and I'm going to turn the presentation over to you.
Thank you so much, Shanna, and thank you so much for inviting me to speak today and for being here. This intersection of Hep C and opioid use disorder is really an important space with so many opportunities for addressing both conditions. And I'm really excited to share some ideas for how we can support Kentuckians towards improved health outcomes for both conditions. Our objectives are by the end of this presentation, you'll be able to recognize current trends and epidemiological trends in hepatitis C in Kentucky and the US. Also to understand our current screening guidelines for Hep C and available treatment options. We're going to explore a number of evidence-based, community-based strategies across the continuum of Hep C care for Hep C, especially for people who use drugs and others at increased risk. And then also, hopefully, you'll understand more how multidisciplinary partnerships, especially at the local level, will help contribute to improved Hep C care and outcomes. A little bit about our program. The Kentucky Department for Public Health's viral hepatitis program is responsible for prevention efforts and enhanced surveillance for adult Hep B, adult Hep C, and perinatal Hep C. A few years ago, our program engaged in elimination planning, where we identified our priority populations, including people with opioid use disorder. I engaged with multidisciplinary partners. Some of you all may have actually been involved in that process. And we identified a number of evidence-based interventions to really expand and encourage Hep C linkage to care. You can access our Hep C elimination plan for Kentucky at our website. Just a note that we really tried to, and we learned that we had to stay what we called syndemic focused. And I'm going to talk a little bit more about what we mean by that. Maybe you've heard the term syndemic in the past. I hadn't heard it until just a couple of years ago. A syndemic occurs when two or more diseases or health conditions cluster and interact within a population. Social and structural factors will contribute and exacerbate these conditions, and this will lead to an increased and excess and disproportionate burden of disease in a population. So the syndemic that we are currently in, injection drug use and opioid use have contributed to and are risk factors for a number of conditions that are basically interacting with one another. We know that people are experiencing substance use disorder, opioid use disorder, overdose, Hep C, HIV, Hep B, syphilis, etc., and that our priority populations, especially people who use drugs, people with substance use disorder, are often at risk of all of these aspects of this endemic, not one. And therefore, it's really important for all of us who are providing care to provide education, increased access to care, and really to help decrease stigma for all aspects of this endemic. So it's important also to understand that although these conditions can interact with one another and exacerbate one another, we also find that the benefits of a syndemic approach really are synergistic. And especially when we're talking about hepatitis C, which comparatively is so easy to treat. It's a chronic condition that has a cure. What chronic conditions can you think of that have a cure? And this kind of relatively easy, of course, we know it's actually not that easy, but relatively easy to achieve cure, even for populations that experience many, many barriers to care that we all are aware of. And achieving this positive health milestone of a Hep C cure can really be a win for individuals who struggle with many other issues of their lives and help them to take control of their lives. This is a study that showed that highly interconnected effects on the quality of life worked synergistically through improved physical and psychological well-being. Stakeholders should appreciate the multidimensional benefits that viral eradication bestows upon individuals and society. And we also find that there are a number of studies that show specifically that integrating hepatitis C treatment into, for instance, medication for opioid use disorder treatment can lead to improved retention in opioid treatment programs, high rates of Hep C cure, or what we call SVR, sustained virologic response, reduced risks associated with drug use, reduced injection drug use, and injection equipment sharing, and then also a reduced Hep C virus and other addiction-related shame. And this can lead to overall improvements in self-care. But unfortunately, we find that integration of Hep C services into MOUD remains low. And this is a study that really showed that this is happening across the United States. And this is really a missed opportunity to engage these at-risk marginalized populations in Hep C and HIV care. And when we come to Kentucky specifically, a study last year showed that Kentuckians on Medicaid who received medication for opioid use disorder were actually less likely to receive Hep C treatment than people who weren't receiving MOUD. And because of these synergistic benefits that we're talking about, and because of the importance of integrating this care into a variety of settings, the CDC identified these 4 priority high impact settings to advance hepatitis C care. You can see FQHCs, Department of Corrections, syringe service programs, harm reduction programs, and then also medication for opioid use disorder programs as well. We know that settings where people are already seeking care are the settings that they really need to be receiving Hep C treatment. They don't need to be going to a different place to get treatment. That's one of the major barriers that people experience, especially people who use drugs, especially people who've experienced stigma in the past. Again, wherever they're accessing care, that's where they should be accessing hepatitis C testing and treatment as well. I'm going to be discussing most of these. This is just a list of evidence-based interventions for increasing Hep C treatment and linkage. Just a note, that these really, we're going to be talking about, again, that co-located care, that integrated care, universal screening for Hep C, patient linkage and navigation, kind of enhanced linkage. We're going to explore some pharmacist-led treatment interventions, nurse-led care, peer support is huge, and then also provider education, patient education, and simplified hepatitis C treatment. I'm going to discuss briefly some hepatitis C basics. I know many of you all are very, very aware of Hep C basics, but just to kind of level set, we're going to just talk briefly about what is Hep C. So Hep C is a viral infection spread when someone comes into contact with blood from a person who's infected with Hep C, blood-to-blood transmission. It's also a leading infectious cause of death in the United States. And this is really important to understand because we don't always think about it, but hepatitis C can lead to death in many people. It's sometimes known as a silent killer because people can have it for many years and not, have experienced complications until much later after they were infected. And it's also a leading cause of liver cancer and liver transplants. And this is especially interesting considering last year, the University of Kentucky reported a record number of liver transplants. And they did not specify how many were related to Hep C, but Hep C is a leading cause for the need for a liver transplant. Looking at the United States as a whole, acute Hep C rates in Kentucky were the third highest out of in the United States, just behind West Virginia and Florida. Our case rate in 2023 was 5.9 compared to the national rate, which was 1.5. You can see that over the past number of years that our rates have remained higher than the national rates. And we also were seeing, from 2019 to 2023, significant increase in cases of acute hepatitis C in Kentucky. When we break our acute Hep C case count and rate down by race, we find that although people who are white make up most of the acute Hep C cases for 2023 in Kentucky, those that are multiracial or listed as other race in our surveillance system are overrepresented compared to their underlying population. When we break that case data down by sex, we find that more males are impacted than females, but still a significant number of females are impacted. When we break that case data down by sex and age, so this is male sex and age, we see that by far the burden of disease is highest in this 20 to 49-year-old age range in 2022 through 2024. Just to note that the 2024 data is still preliminary. And this has been, you can see also that this has kind of changed from year to year. We're also seeing a little bit of an increase in this 50 to 69-year-old age range that we weren't seeing so much in previous years, but still important because when I went to nursing school, we learned that baby boomers were most impacted. And although there is still a disproportionate burden of disease in the baby boomer population, these acute cases, these newer cases we're finding in younger populations. When we break that case data down by age and female sex, we see the same thing, higher rates in this 20 to 49-year-old age range. And this, of course, has impacts to those women who have acute Hep C, but also their perinatal perinatal exposure implications as well. And indeed, we see that over the past number of years, and unfortunately, we don't have the most recent data, but we were seeing a significant increase in perinatal hepatitis C exposure in the state in recent years. It's really important to note that I was just talking about mostly acute hepatitis C case data, and this is just, you can see in this, I think it's a great sort of visual representation. This is just the cases that were reported to us. Acute hepatitis C is a reportable condition in Kentucky, and so we do receive acute case data, but that is just a portion of the number of people who sought medical care, the number of people who experienced symptomatic illness out of the total acute Hep C infections that are occurring in our population. It is estimated that about 50% or more of people with hepatitis C don't know that they have it. Also, many people are diagnosed with chronic hepatitis C, which is not a reportable disease in Kentucky. So we have to kind of estimate those rates in our program based on the lab data. This is a map showing the RNA positivity rate by county. Like I just said, our program receives lab data for hepatitis C across the state. And so, although RNA positivity rate is kind of a complicated measure, you can see the counties that have the highest positivity rate. So out of the number of tests that was done in that community, this was the rate of positive tests. And even though, even if you live in or work in one of these counties that is lighter colored, it is possible that just less testing is happening in those communities. This is a map showing the lab-reported Hep C antibody tests that are done in a given county by the population per 100,000 people in 2024. And you can see that kind of different in different parts of the state, but I just want to note specifically this really dark county right here, which is Harrison County. There's a specific program going on there right now that's where they're doing universal opt-out hepatitis C testing in their hospital. And that is what is contributing to them having a higher antibody testing rate. So we know that a lot of testing is being done in that community, really specifically because of this program that's happening in the Harrison Memorial Hospital. And then we can see in other counties that much less testing is happening as well. We can't know if someone has Hep C unless they get tested. So we'd love to see these counties be doing more Hep C testing. I wanted to just briefly talk about hepatitis C in carceral settings. The proportion of Hep C is much higher in correctional populations than in the general population, about 10 to 50% versus 1%. Also, an interesting study showed that 30% of all individuals living with Hep C in the United States will pass through a correctional system in any given year. And we know that the vast majority of people who are incarcerated will be released back into their communities at some point. And so this really is a community health issue. Through a partnership that our program has developed with the Kentucky Department of Corrections, we've been able to develop what we call a hepatitis C cascade of cure. This is from the end of 2020 until the end of 2023, so not all of 2020 is represented here. But out of 11,000 people tested during that time, you can see a significant number, about 4,000, were exposed to hepatitis C, so had that positive Hep C antibody. About 3,000 were infectious or had that positive RNA confirmatory, and then only 423 people during that time initiated treatment. 193 achieved cure, proven cure, that SVR, and 24 were reinfected. You can see the treatment initiation by year on the right. So just, again, 2020 is only partial data, but we can see the number of people that were treated by year. This is especially important considering Kentucky's really high incarceration rates. We also have had increased, the number of women incarcerated in Kentucky's prisons has increased recently. Again, this is relevant for the health of those women that are incarcerated, but also, again, the risk of perinatal exposure is increased as well. Another note about risk factors: injection drug use, as you probably know, is the most commonly reported risk factor for hepatitis C, and it's estimated that around 40% of people with a recent history of injection drug use are living with hepatitis C. But that's not the only way that Hep C is transmitted. Really, using non-sterile equipment to prepare and or inject, inhale, or smoke illicit substances has the potential for Hep C transmission. Tattooing or piercing using non-sterile equipment or procedures, sexual contact when blood is present, medical procedures with non-sterile equipment. Of course, that doesn't happen frequently in the United States, thankfully. Needle stick injuries do happen, though. Sharing toothbrushes, razors, or nail clippers can transmit Hep C if blood is on any of those. This is rare, but it especially can occur in a congregate setting, such as a jail. And then there's a risk for perinatal transmission as well. I just want to note that Hep C can live on certain surfaces for up to 6 weeks. And so that's why, some of these these transmission methods we don't really think about, but if blood is present, and that blood could be present, for a significant amount of time outside the body and still have the potential to transmit Hep C. Just a short note about perinatal Hep C. Perinatal means the period before, during, or shortly after birth, of course. Chronic Hep C infection will develop in about 6% of all infants exposed during pregnancy or delivery. And Hep C treatment can only begin starting at 3 years of age. So it's so important that we get, and we're going to talk more about testing later, that we get those infants that are exposed tested for Hep C in the appropriate time period, and also that we get them linked to care so that they can get treatment starting at 3 years of age if they test positive. It's also important to know that Hep C cannot be transmitted by sharing clothing, eating utensils or food or drinks, coughing, kissing, hugging, holding hands, or breastfeeding. Now that we've kind of taken a minute to talk about the basics, we're going to move into what can we do about it. We see that this is a problem in Kentucky. We see that Kentucky has a disproportionate burden of hepatitis C. So what can we do about it? And this is the time when I like to pull in this quote from Nathan Furukawa, a doctor and senior advisor for hepatitis C elimination at the CDC. And he said in 2023 that Hep C is a virus that flourishes among those who are socially marginalized by structural factors such as poverty, racism, addiction, and trauma. And even though we have these highly effective, highly cost-saving medications, direct-acting antivirals or DAAs, they are not reaching the people who need them most. And we need to recognize that Hep C elimination is only possible by focusing on these most marginalized and difficult to reach populations to bring them into care, not just for Hep C, but again, for all of the syndemic conditions that may impact them. And the way that we like to visualize how we can intervene, how can we make an impact on these high numbers of Hep C and low numbers of treatment for Hep C. And we like to think about the hepatitis C continuum of care. Of course, there's many continuums of care out there. This is one for Hep C. And you can see that it really spans all the way from primary prevention, education, awareness, all the way to screening and treatment, access to treatment, confirmed cure, and then reinfection prevention as well. And all the while we need to be reducing harm, all the while we need to be decreasing stigma, and all the while we need to be reducing barriers to care. Just a second. So how can we do that? Our first goal along that continuum of care is increasing hepatitis C awareness and education. How can we do that? Prevention discussions really should be happening during as many visits, patient visits and interactions as possible, especially if we know that someone has opioid use disorder or has a history of substance use. We need to be sharing information about prevention and transmission. So that includes information about avoiding sharing syringes, pipes, straws, or any equipment or surfaces used to prepare drugs. It needs to include information about utilizing syringe services programs and harm reduction programs in the state. It needs to include information about safer sex, utilizing professional shops for tattoos and piercings, and utilizing sterile equipment. Again, avoiding sharing toothbrushes, razors, nail clippers, and other hygiene supplies, especially in those congregate settings. It needs to include information about getting tested. Getting tested can prevent Hep C because, one, if someone knows their status, they can change their behaviors. Two, they can get treatment, right? And getting cured can prevent hepatitis C because once someone achieves cure, they can no longer transmit Hep C. And really encouraging people not to wait to get treatment because early treatment can not only prevent further liver damage, but also can prevent transmission. Of course, communication is important for people to be thinking about, and also reinfection prevention needs to include these same points, because if someone achieves a hepatitis C cure, they could still go on to become reinfected. Just a map of the syringe services programs across the state. Many of you all know that we have a number of syringe services programs, and we should be sharing information with our patients about how to access those and what resources that they have available. Also, just a note, many of you all know that our syringe services programs, the services that they provide are wide-ranging and comprehensive, and in addition to offering sterile syringes and safe disposal of syringes, often they offer HIV and Hep C testing, counseling, in-house treatment, linkage to care, among a number of other services as well. Another way to provide Hep C education is through materials. These are some of the materials that our program has created, and you can access these materials by scanning this QR code. I'll also be sharing this in our follow-up email with a list of our resources. Our program has created a lot of different materials provider education materials, patient education materials for focused populations, a lot of perinatal hepatitis C educational materials as well. We really encourage you to access these and print them yourselves. And also, if you'd like for us to send you some, we would love to do that. Just I'll drop my email in the chat, and also again, I'll be sending a follow-up email as well. Our next goal, again, remembering back to the continuum of care, is to increase hepatitis C testing. It's important to know that many people with chronic hepatitis C will have no symptoms for a long time. The only way that someone can know if they have hepatitis C, of course, is to get tested. It's also really important for providers to know, and for everyone to know, that the CDC changed their hepatitis C testing guidelines in 2020. At that time, they changed the guidelines to where every adult should be tested at least once in their lifetime, and we should not only be testing for risk factors. People with risk factors should be tested more regularly, such as often as every 3 months. But again, every adult should be screened at least one time in their life for hepatitis C. Testing should also occur during every pregnancy. And again, I really want to reiterate this universal hepatitis C screening importance, because unfortunately, as we know, there was a lot going on in 2020, and unfortunately, a lot of providers have not received this information, or have not integrated it into their practices. And so a lot of primary care providers are not doing universal hepatitis C screening. And by doing hepatitis C screening, we will definitely be identifying a lot more people with hep C that are unaware of their status. As you maybe can remember, I referenced earlier, up to 50% of people with hep C don't know their status. So that's one of the reasons for the importance of universal hepatitis C screening. Also, we know that patients will not always disclose their risk factors. And so that's another reason why we should be universally screening for hepatitis C. I'm going to spend just a brief amount of time talking about hep C testing methods. The most common method, of course, is through phlebotomy. Just a note that we can test for antibodies this way, hep C antibodies, and that a reflex to RNA test should be done to confirm if someone has a positive antibody, to confirm if they have a positive RNA, which would mean that they were actively infected and would potentially need treatment. There are also point of care antibody tests available, specifically the OraSure OraQuick Hep C antibody, Hep C rapid antibody test. This can tell whether someone's been exposed to hep C. Again, that antibody positive would say that would tell us whether someone has been exposed to hep C, but this would require further diagnostic testing to confirm whether someone has an active infection and may need treatment. Last year, the FDA authorized the Cepheid CLIA-waived expert point of care hep C RNA test. So this point of care test, again, point of care just means that we receive the results at the time of the test, can tell us whether someone has an active infection, has that positive RNA, and needs treatment. This is also a finger stick, so the OraSure was a finger stick. This is also a finger stick. It takes a bit more blood, and it takes a bit longer for the results to come back, for the results to result. But this really can reduce the time and steps that it takes to get to hep C treatment. Just a short note about testing for infants who are exposed during pregnancy. All babies exposed during pregnancy should be getting an RNA hep C test, a hep C RNA test, when they're 2 to 6 months old. So starting at 2 months old, they can get a hep C test. This is a change. In 2023, the CDC changed their guidelines. Before that, we had to wait until 18 months of age to test for an antibody. But the CDC changed their guidelines again. Hep C RNA test starting at 2 months of age. If the infant tests positive, again, that they really need to be linked to hep C at pediatric hep C providers, and they need to be, or they can receive treatment starting at 3 years old. I also wanted to briefly touch on electronic reporting. For the reportable hepatitis, adult acute hep A, B, C, positive pregnant female with hep C, and a perinatal hep C or exposed infant. These are all the reportable hepatitis. Historically, we've used paper forms like you can see here on the screen. We're trying to move towards electronic reporting. And so if your facility is not set up with this direct data entry, you can reach out to KHI support@ky.gov to receive information about how to transition over to electronic reporting, which we're really recommending. Goal number 3, again, thinking back to our continuum of care, is to increase Hep C treatment and cure. Today's Hep C treatments are way different than they were when I was in nursing school. When I was in nursing school, there was interferons were the only treatments that were available. They weren't very effective, and they were really difficult to take. Today's treatments, those direct-acting antivirals, or DAAs, have cure rates of more than 95%. They're easy to take and have few side effects. They're covered by most health insurance. They should not require sobriety. They're pills taken daily, and they're completed within 8 to 12 weeks. But unfortunately, these cures, these to me almost miraculous cures for a viral infection, are not reaching the people who need them. Less than 1 in 3 people with health insurance are receiving treatment within a year of diagnosis. This is even lower for our Medicaid patients, less than 1 in 4. And it's just so important. This visual is so important as we, again, think about our most vulnerable populations, as we think about our most stigmatized populations, and how we can really decrease the barriers to care. Because most of the reasons that for these low treatment numbers is because of the barriers to care. So our last goal is, how can we address barriers and link people to hepatitis C treatment and cure? So there are a number of barriers to Hep C treatment, and I've kind of broken them down by provider level barriers and patient level barriers. And many of you all are aware of these. These are many of the same barriers that we see for people accessing any kind of health care. But we know that there is an overall lack of awareness of Hep C among providers. We know there's a low number of Hep C treatment providers, period. Many, as we discussed earlier, providers aren't even screening for or testing for Hep C following the CDC guidelines. We know providers don't have very much time. Many don't have experience testing or treating for Hep C. They may have difficulty managing medication interactions with Hep C medications, of course, communication issues with patients, and provider stigma as well. A lot of these barriers are based on, a lot of the barriers that we see with providers for providing Hep C treatment are based on kind of old rules that we had, old restrictions that we had for Hep C treatment being covered by insurance. In the past, there were many restrictions for Hep C treatment. Specifically, only specialists were able to prescribe treatment. Now, a lot of these treatment restrictions are gone, and the only ones that remain are retreatment restrictions related to sobriety. So although someone does not have to prove sobriety for initial treatment, they do have to provide proof of sobriety for retreatment. There are also prescription limits, so providers can only prescribe a 28-day supply at a time. And then there's also a lengthy prior authorization that can really be an administrative barrier for a lot of people. Our program is working on removing these last barriers, but just a note, specifically, specialists are not required to treat Hep C. Really, any provider that can prescribe Hep C treatment can treat Hep C. And just a note that Hep C treatment can be and is provided in some emergency departments across the state, in many primary care settings across the state, and in MOUD treatment settings as well, in substance use disorder treatment. We know that not everybody's going to want to get tested or treated, but the more that we offer and the easier that we make it to get Hep C testing and treatment, the more people are going to be treated. Just a brief, I know that we have some pharmacists on the call. I just wanted to note that, this is just one example of a pharmacist-led initiative for Hep C treatment. The University of Kentucky Emergency Department has a Hep C treatment program where pharmacists are really leading almost all aspects of hepatitis C screening, testing, and treatment as well. And this is a study about that, or an article about that program. We've created some materials focused on increased hepatitis screening and treatment and primary care, just helping primary care providers know that they should be screening everyone for Hep C, that they can treat Hep C. And again, we don't need to be sending most people to specialists. Of course, there are going to be people who need to be seen by a specialist if they have other exacerbating conditions, but the majority of people with hepatitis C can be treated by primary care providers or nurse practitioners, people working in MOED settings, right? Again, anyone that can prescribe Hep C treatment could potentially, could be a treatment provider. This is a visual of the simplified treatment algorithm for treatment-naive patients from the American Association for the Study of Liver Diseases, the AASLD, and the Infectious Disease Society of America. This is just to show you kind of how simple the simplified treatment algorithm is. And again, this is the treatment that would be appropriate for most patients. This will help to identify patients who would not be eligible for Hep C for simplified treatment. Again, this can be done by physicians, by nurse practitioners, by primary care providers, and substance use disorder treatment clinics in a number of settings. This is another treatment algorithm that was released just this year by the AASLD, the Screen and Treat. This is utilizing that newly approved Cepheid point-of-care RNA testing machine. And with this kind of algorithm, we can potentially test and treat in 2 visits. And you can see that treatment algorithm here. Again, this won't be appropriate for every patient, but it does show that we're moving towards more and more simplified treatment guidelines for patients with Hep C. If you or anyone that you know is interested in learning more about Hep C treatment, there's a program called the Kentucky Hepatitis Academic Mentorship Program, or CAMP. This is run by the Kentucky Rural Health Association. It's for providers across the state who are interested in providing Hep C services in their local communities. It's easily accessible training that includes one-on-one ongoing mentorship and support from providers who are really experienced in providing Hep C treatment. If your facility is not able to provide Hep C treatment on site, there are other options to facilitate treatment. This could be through telehealth partnerships. So someone that is utilizing your clinic, maybe for medication for opioid use disorder or whatever, your clinic could potentially partner with a clinic that treats hepatitis C and offer telehealth partnership that way. That's something that is going on, and I'll just share a little bit more in a second, in some of our syringe services programs across the state. Also just sharing space, providing space for a Hep C treatment provider in your clinic. Also this enhanced linkage. Mobile clinics, I've heard examples of substance use disorder treatment clinics having a mobile clinic set up in their parking lot so that they can maybe test for and treat Hep C on site there at the substance use disorder treatment clinic. Some of our local health departments are doing treatment, and many primary care providers, FQHCs, community health centers are doing Hep C treatment. Some substance use treatment clinics are also doing treatment. Just like knowing who's doing treatment in your community and being able to facilitate that enhanced linkage, really helping to actively link people to care, can be so effective as well, again, if your facility is not able to treat Hep C on site. Again, this is a telemedicine partnership that the University of Kentucky has with some Kentucky syringe services programs where they are providing Hep C treatment to those SSP participants that are interested in getting treatment via telehealth with a UK provider in their communities. You can see the dots where those sites are. Those are expanding as well. This is kind of an old map. There are a couple of additional sites that have been added as well across the state. And again, just being aware of these, being aware of who's treating in your community can be really helpful for your patients. Because a referral for Hep C treatment is often not enough. If you all are doing treatment or testing, or one of your patients tells you that they have Hep C, that they know they have Hep C, doing a simple referral is often not enough. We know that. many of us have experienced that. Letters, phone calls don't reach people, scheduling difficulties can arise, and that enhanced linkage, that really warm handoff to a Hep C treatment provider can make such a huge difference, especially again for our most vulnerable populations, especially for our patients that have experienced stigma in the past. I like to note just briefly that Hep C treatment is not substance use disorder, injection drug use is not a contraindication for Hep C treatment. We should be treating people who actively use drugs and people who are in substance use disorder treatment. This can really significantly reduce this Hep C transmission, like among injection drug use networks. Also, from a public health perspective, we really need to be treating people who become reinfected. We should really be providing that full access to treatment, again, in those injection drug use networks to reduce that community viral load, because over time, that will reduce the overall, like I said, the overall community viral load. And, you know, it is true that the more we treat, the more reinfection will occur. But this study showed, this HERO study showed that while there may be an initial increase in reinfection, that incidence will fall as population level Hep C RNA prevalence declines. Another barrier that patients experience is healthcare provider stigma. I'm sure I'm not the first person to talk about healthcare provider stigma with you. This is just a visual showing the number of published research articles referencing provider stigma over the past many years. We know the stigma surrounding substance use disorders is a frequently cited barrier to treatment engagement, and that healthcare professionals' attitudes towards their patients, especially with addiction problems, are often negative and may adversely impact service delivery. This is true for Hep C treatment, Hep C patients as well. When people experience stigma from healthcare providers, they become less likely to seek care when they need it, and this can often make them unable to get what they need to stay healthy, such as Hep C testing and treatment. This is just one resource about addressing stigma. From the Syndemic in Tennessee, they have a lot of really great resources. This is just one, again, just talking about, maybe you've heard it before, or maybe it's important in your practice already, but using person-first language, treating people as they wish to be treated, and really whenever possible, using value-neutral language as well. Because ultimately we know that people use drugs when we see them in our clinics. They're seeking healthcare. They're doing their best. They're people's parents, siblings, children, colleagues, and community members. They care about their health, and they deserve to receive high-quality healthcare and to live. And we also know, I know that many of you all know, substance use disorder could impact anyone. It's not the lack of willpower. Is a treatable mental health condition, not a crime, and that there are many evidence-based ways to treat hepatitis, or to treat substance use disorder, including, of course, MOUD. And this is just another plug for that co-location, for that integration of Hep C care into medication for opioid use disorder and other settings, because offering Hep C services on site in the places people are already accessing care is how we're going to reach the people that need it. If you'll remember back to the visual, less than 1 in 3 people who have a Hep C diagnosis are getting Hep C treatment within a year of their diagnosis. We need to remember how important providing care in the places they're already seeking health care is. And again, even if you're not able to provide on-site testing or treatment, being aware of where people can get testing and treatment, being aware of which person-centered Hep C treatment providers are out there, developing those relationships, providing those warm handoffs, helping patients to make phone calls, helping them to navigate care, and ideally engaging peer supports at every step of the way, because peer supports in themselves are an evidence-based intervention for so many aspects of the syndemic, but they've also been proven effective in increasing hepatitis C awareness, testing, as well as treatment uptake and engagement. In addition to all of those provider level barriers to Hep C treatment, there's also the patient level barriers as well. We know patients overall have a lack of awareness about Hep C, and then all of the other barriers that many patients have to accessing healthcare, lack of health insurance, lack of ID, lack of a phone, email, or mail access, lack of transportation is huge. Housing instability, and all of the kind of complications that arise with that. Not being able to receive a medication or being able to access a pharmacy, nowhere to store medications for some of our unhoused individuals, and of course, past negative experiences of healthcare stigma. So some ways of addressing some of these, of course, having connectors on site to help people connect with health insurance, also helping people to do this by phone or by online if needed. Also, there are, of course, well, many of you all know there are prescription assistance programs out there that can help people that are uninsured. There is a program at the Kentucky Department for Public Health called KPAP, or the Kentucky Prescription Assistance Program. KPAP helps qualifying individuals identify sources of free and low-cost medications offered by pharmaceutical companies. This can potentially include hepatitis C treatment. People can actually become KPAP advocates. It's a training. Actually, community health workers can get a CEU hour for participating. You can reach out to them. They can help people via their hotline, but also advocates can be trained to help people as well. I know a number of clinics who have had some of their staff trained to become advocates so they can provide more assistance for people that are needing to access prescription assistance programs. As far as transportation technology, again, on-site testing and treatment, integrating our services, co-locating our services is huge here. If someone has transportation to get to their substance use disorder treatment clinic, then they will also have transportation to get to Hep C treatment if it's offered there. Also, some programs are able to provide incentives like gas cards, bus passes, etc. Offering flexible scheduling can be really important for patients needing that. And as far as housing, there are, of course, helping people to get connected with housing assistance programs, but also we can kind of get creative. This is you can see a picture of a creative solution that one of our partners, Solutions Health in Louisville, has provided their community, which is lockers for some of their unhoused patients to store their Hep C medication. Hep C medication is expensive, we know, and health insurance companies aren't going to want to replace treatment if it's lost or stolen, and so they are able to provide these lockers on site to help their unhoused population store their medication safely. And no matter what your clinic or your practice is doing regarding hepatitis C, again, thinking that full continuum of hepatitis C care, we can be gathering Hep C data as well. So just looking into your practices and seeing, are all clients offered Hep C education? If you do testing, are all clients offered hepatitis C testing? And if you test, gathering data about how many people were actually tested. And if a facility treats, how successful is treatment and achieving cure, that SVR as well. And then if a facility doesn't treat, what about the linkage piece? Is linkage happening? Is that enhanced linkage happening, those warm handoffs? And is that linkage being provided successful? So to sum up, and I've still got a couple of things to share, but kind of to sum up this part of the continuum of care, there's so many ways to intervene to help eliminate hepatitis C. You can, no matter where you work, you can be providing helpful, accurate information about hepatitis C. No matter where you work, you can be decreasing stigma around substance use disorder, around Hep C infection. And no matter where you work, you can be advocating for increased Hep C services, that enhanced linkage, that care navigation, peer support engagement. We really need to be advocating to meet our patients where they're at and offer person-centered care. And then, of course, facilitating linkage along that continuum of care. We know that often to do what we're asking you to do, to increase services, that funding is needed. And we have been trying to gather information about what options are out there for, helping to fund Hep C testing, treatment, increased education, et cetera. And one potential option could be opioid abatement funds. And we've created this resource to share about it because Exhibit E of the 2023 Commission TIVA Global Opioid Settlement Agreement states that opioid abatement funds can be used to expand access for testing and treatment for infectious diseases such as Hep C resulting from intravenous opioid use. So we know that it could potentially, of course, I'm not a lawyer, I can't offer legal advice, but these funds could potentially be used and are being used in other states for hepatitis C care. There's a lot of options here to scale up testing, expand treatment access, help to provide those wraparound services to support treatment and cure. This could be done in jails, it could be done in clinics, it could be done in local health departments. There's just a lot of opportunities here. And again, we're seeing this in other states. We're not seeing it in Kentucky so much quite yet. This is just a screenshot of that verbiage from the settlement. So some possibilities for how to use the opioid settlement funds. Again, these a number of settings could increase Hep C education, screening, testing, and treatment, hiring testing treatment providers, hiring peer supports, linkage coordinators, providing incentives or support for testing, treatment, and cure. For more information for the state funds, or just the funds in general, you can see the Kentucky Opioid Abatement Advisory Commission. For the county level funds, you can talk to Lauren Carr or Kentucky Association of Counties as well. Some other potential funding sources for Hep C care. For some local health departments and clinics, 340B partnerships and 340B savings can be a really helpful way to support hepatitis C care. Of course, it requires 340B eligibility and partnerships with pharmacies, et cetera. But that's one potential sort of use of those savings. Also for I learned recently from the Kentucky ASAP that County Agency for Substance Abuse Policy Funds, or ASAP funds, could potentially be used for Hep C test kits at least. Of course, these need to be line items and a budget, and they need to be approved by the Office of Drug Control Policy. And for local health departments that are Kentucky Overdose Response Effort or CORE Harm Reduction Expansion Project awardees, they could potentially, again, budget for it and use funds for Hep C test kits as well. For more information, of course, you can reach out to the Harm Reduction Program at the Kentucky Department for Public Health. Another note, and I'm just going to kind of gloss over this, but there, for our carceral settings, there is the Kentucky Medicaid Reentry 1115 waiver demonstration, which will hopefully, and I think, or may already be expanding services in state prisons and youth correctional facilities for case management, medication for opioid use disorder, and some prescription medications upon release and equipment. Future renewals of this waiver, we would love to see incorporate hepatitis C testing and treatment, which they don't currently cover, but we would love to see future iterations cover this, expand to 90-day coverage to cover the full time that it takes to complete Hep C treatment. And also we'd love to see it expand not only our state prisons and youth correctional facilities, but also our local jails. This is a list of resources that I'll be sending out to you. Some more resources. And to kind of bring it all back to the beginning, Hep C elimination in Kentucky communities is really going to take all of us. We know that local programs, not just us kind of at the state level, are going to be ultimately much more successful in progressing towards Hep C elimination. We'd love for you to be thinking, brainstorming, how can we increase Hep C services in your community? If you need technical support or technical assistance, please let us know. And I love this little image that was shared at a presentation I went to a few months ago, just showing Hep C. It took us, this was 10 years ago, so I had to change it to 35 years to bring him to his knees. Now let's finish him off. Hep C elimination is totally possible. There's a cure for this chronic condition, and it's going to take all of us again and doing what we can to increase access to these most vulnerable patients and getting them cured. tested and cured. This is our contact information, and it looks like I left just a few minutes for questions if anyone has any questions.
Cindy, thank you so much for all this wonderful information. We do have a few minutes. If anybody has a question, you can now unmute your line, or if you'd rather, you can type it into the chat box.
And I just want to note too, I put my email in the chat. You can see our email, our program email too. If you have questions that you wanted to reach out later, of course, please feel free.
I also just wanted to mention the Hep C educational materials and the educational flyer, Katie, that you showed earlier in your presentation. We do have links to those available in the KYSOS newsletter, and I believe they're on our KYSOS website. I'll double check that and make sure those are up as well.
Great.
For access. Yeah.
Thank you so much. Yeah, that's fantastic.
Okay. Well, if we don't have any questions, like Katie said, her email is in the chat. So if you think of something that you want to ask, I'm sure she'd be happy to answer your questions. Again, lots of great information on Hep C and substance use disorder today. Katie, thank you so much again. And thank you to everybody who joined us for our webinar today. And I will give you guys back a few minutes of your day. Everybody have a great afternoon.